Hello, everyone. I'm Dr. Carmen Puliafito, and I'm here with Dr. Amir Kashani, who is the T. Boone Pickens Chairholder in Ophthalmology at the Wilmer Ophthalmologic Institute in Baltimore, Maryland. Amir, welcome to Retina Synthesis.
Thanks for having me, Carmen. I'm excited to be here.
Well, you've been working on an exciting project over the last couple of years, which is the retinal stem cell implant for treatment of geographic atrophy. Can you start off by telling our audience what the concept is behind the implant?
Right, sure. So as everybody knows, geographic atrophy and dry age-related macular degeneration is a huge unmet need. Once those RPE cells are gone, there's really no way to replace them. And whether you're talking about gene therapy or complement inhibitors. So there's a large population of patients who are not going to have treatments with any of the conventional treatments that we have. So the way to approach it is to potentially replace those RPE cells if we can do it early enough to either restore some vision or prevent further vision loss. And so the approach that we've taken is to make a biosynthetic implant. It's called the California Project to Cure Blindness, RPE1. I just want to actually give a acknowledgement to the California Project to Cure Blindness actually for funding this, because it was really important, and I was very thankful that both California and the people of California actually voted that in and made it happen. So we appreciate that. But basically, the idea is to have this monolayer of mature RPE cells that are grown on a synthetic parylene membrane. That's about a 3.5 by 6.25 parylene membrane. And to implant that monolayer of cells within the area of geographic atrophy to hopefully allow those RPE cells to revive or resurrect any residual photoreceptors in that area, and also to provide trophic support to surrounding photoreceptors and the underlying choroid and choriocapillaris, and at the very least prevent further vision loss in that area. So.
And the cells are derived from, the RPE cells are derived, allogeneic cells derived from RPE cells, from right. Stem cells.
That's right, yes. They're stem cell derived RPE from human embryonic stem cells. Yeah.
And you put them on the implant, and are they stored? Are they pre-manufactured, the implants?
They are pre-manufactured, but these are fresh implants. In the current iteration of the project, these are fresh implants. So they're made approximately 30 days before the surgery is designed, is scheduled to happen. They're made custom for that patient and delivered to the surgical site for implantation.
So can you tell us a little bit about the study design?
Sure. So this was a phase 1/2A study, primarily for safety. It was prospective, non-randomized, open label. We were aiming to recruit about 20 subjects into the study, and we recruited 16 and stopped at that point because we felt the results were compelling enough, or the sponsor felt the results were compelling enough. And basically, each subject that was enrolled in the study had to have advanced dry AMD with fovea involving geographic atrophy. They had to be pseudophakic, and their visual acuity had to be worse than 2200 effectively in the cohort. Originally, we had them split into two cohorts, and the first cohort was supposed to have 2200 or worse, and the second cohort was 2080. But in effect, everybody ended up having 2200. So just to make it simple. And each of the subjects underwent a single outpatient surgery for placement of this implant, using an investigational device as well that folds the implant and allows us to place it into the subretinal space using a pars-plana vitrectomy approach. And so it was all done outpatient surgery, and they were discharged home. All of the procedures that were used during the implant were with commercially available instrumentation. The only part of the surgery that was not with commercially available instrumentation is just the injector, which is part of the IND, and the actual the biosynthetic implant itself.
How many centers were involved?
The patients were recruited from up to 6 centers in Southern California and Arizona, and USC was the only surgical center there.
Mm-hmm. So tell us what the results are. Now, we've had we have more than 2 years follow-up on these eyes, correct?
Yeah, so we're at three, actually. We're more than 3 years on many of them. So we just reported the 1 year results end of last year, actually. And the results have been good. So basically the primary outcome was 1 year safety at 365 days. And we looked at visual acuity, and we looked at fundus photographs and clinical exams and OCT. And at 1 year, essentially, there was no safety signals. There was systemic serious adverse events that were not associated with the implant or the surgery, and they were not related at all. And there was 4 out of the first 6 subjects had some hemorrhage that was classified as serious adverse events, and we were able to modify the surgical procedure to avoid that in the subsequent 9. And so really there's no safety signal that resulted in any concern at 1 year. The visual acuity was unchanged between baseline and 1 year results. It was around logMAR 1.3. And what was encouraging was that at 1 year, none of the implants migrated. There was no sign of inflammation. There was no sign of any mass lesions or any growth, that was part of the safety signals that we were looking for. The implants were all pigmented at 1 year, suggesting survival of the RPE. Actually, what was very encouraging was that 27% of the subjects at 1 year demonstrated greater than 5-letter improvement in the treated eye, whereas only 7% of the untreated eyes improved. And I think somewhere like 66% of subjects either maintained or improved in the implanted eye, in contrast to, I think, 40-some% in the non-implanted eye. So
all of these eyes had foveal involvement of the geographic atrophy with full CRORA, and they had the implant was under the fovea in all cases. Is that correct?
In all cases, yeah, we were able to target it very effectively. And it covered more than 80% of the area of geographic atrophy as a median for the whole group. And these are large areas of atrophy in most cases, and these are advanced. Mm-hmm. So we were really able to effectively target it just to the area of atrophy.
So were there any OCT correlates to the improved vision?
Yeah, so it appeared that in some of the subjects there was reconstitution or at least reappearance of the external limiting membrane overlying the implant.
That's exciting.
That is really exciting, yes.
So explain why you believe that your team believes that this is better than injecting a subretinal suspension of RPE cells.
So, well, I mean, it's different in several ways, right? So when you're injecting, this implant is mature polarized RPE, right? So it's characterized very well before it's put in. These cells have apical microvilli. They express markers of mature RPE differentiation. They are a monolayer. They have the appearance and consistency of mature RPE. And just as importantly, the paraline membrane that is part of this implant is actually 6 microns thick with sub-micron thick sections in it, which is designed to mimic the diffusion properties of Brooks membrane. That's the whole reason it was made by the design team here. And that, by the way, was designed by Mark Hermione's team and the tremendous amount of effort that they put into it. And so I think it's significantly different than just putting in cell suspensions, because in suspension, even though the cells could be characterized before they go into suspension, once the cells are not adherent, it's very hard to know exactly what their differentiation state is in the eye. And so it may be a great form of therapy for some forms of degeneration, macular degeneration, but it's very hard to be confident of what the cells are actually doing in vivo. And so that's one big difference. The other big difference is that just anatomically, you want to mimic the normal anatomy of the eye. And so if you're putting in a monolayer, and in all the cases, the monolayer stayed a monolayer, it's much more likely to restore vision, not cause distortion, stay in place, and hopefully behave like the RPE that was there before.
Well, one of the things that I understand is that there's no evidence of an immune response to the implant.
That was a big question for us, and I think for everybody. And we didn't see any signs of any kind of inflammation. I mean, there's typical post-op inflammation in the first month, just like any kind of vitrectomy. But there was nothing. There was no vitritis. There was no anterior cell. There was no vasculitis, no choroiditis, retinitis. I mean, we were looking for that all the time, and we didn't. And the really amazing thing is, these were not HLA matched subjects, right? There was no attempt at HLA matching. And in fact, not only were they not HLA matched, none of the subjects actually matched at more than 50% of the HLA 1 and 2 alleles that we looked at. And we looked at 16. So they're horribly matched, actually. So the fact that there was no clinical immune response is just amazing to me, and I think is very promising for allogeneic cell-based implants.
Why do you think there was no immune response?
That's also a great question. So some people, would have predicted an immune response. I think it's a combination of several things. So first of all, I think when we did the surgery, there was a peri-operative short course of tacrolimus, and there was some intravenous steroid at the time of surgery. It's a very short course at therapeutic levels that are very low for tacrolimus. So I think that perioperative window of steroids and immunosuppression probably helped. We don't know if it was absolutely necessary, but I think it probably helped to prevent inflammation at the time of surgery. And secondly, by putting in mature differentiated RPE, there is reasonable evidence that suggests RPE have immune modulatory function in the retina. They can actually suppress immune responses, suppress T cell responses within the retina. And they do that in vitro. And so it's very likely that the RPE cells themselves are actually mediating some kind of immune response. I can't prove that. We don't have any evidence to that effect, but I think there's kind of enough evidence in the literature that is one potential mechanism by which it could be happening. And of course, the most obvious one is that it's an immune privileged site. There's probably some controversy about whether it's still immune privileged in a disease state when it's got geographic atrophy, but it's an immune privileged site, and so that would play into it.
What's the next step in this project?
The next step in this project is to do a phase 2 or phase 2/3 study, and to do that with cryopreserved implants at multiple sites with multiple surgeons, and try to look for the efficacy signal that we believe will be there if we can do that study.
That's great. Well, listen, this was an exciting discussion about something that's been out there for 10 years, really, in discussion. It's been a very well-developed project by the team at USC and at Caltech, and now at Hopkins. So very good. Thanks, Amir, for your participation in retina synthesis.
Thanks so much, Carmen. Can I just say a quick thank you to some people?
Yes,
especially,
please.
I just feel I was honored to be part of this study, and I really want to say thank you to the patients and their families who were involved in this. I was so amazed at the dedication. The first patient that enrolled in this study told me, she took me by the hand and she said, whether this works or not, I would do it over again. And, thank you for doing this. And I just, I think there's so many people out there who need a therapy. And so thank you to the patients and the families, to, California Project to Prevent Blindness, and also Mark Hamayan, Dennis Clegg, David Hinton, and Jane Lipkowski for the amazing opportunity and leadership to really put this together. And thank you to everybody. And to you for inviting me and being a supporter. I really appreciate it.
Thank you very much.